Hello, and welcome to the November RIV call on T1 Detect, clinical trials, and health policy. Today's speakers are Anastasia Albanese O'Neill, Director of Community Screening and Clinical Trial Education, and Erin Turner Pfeiffer, Director, Health Policy.
Hi, everybody. Thank you for joining us today. I have the privilege of talking about exactly what Brian mentioned, community screening and clinical trial education. And we're going to start with global universal screening, which, as you can see on the slides here, is one of JDRF's top 5 research priorities at this time. So to set the context for global screening, we need to just back up for a second and talk about the stages of type 1 diabetes. And as you know, in the medical standards of care in diabetes in 2015, JDRF led an effort to stage type 1 diabetes and specifically stage pre-symptomatic type 1 diabetes. So as you can see on the slide here, we know there's a genetic risk. There is some environmental trigger or some interaction with the environment. And what we see is an immune response resulting in the productions of proteins in the blood or autoantibodies. In stage, and I'm going to go over these stages in the next slide, but what we know now is that we can identify individuals at risk for what we call clinical type 1 diabetes or stage 3 many years in advance. And I'm going to move to the next slide to illustrate this a little bit more easily. So we are looking for autoantibodies, again, proteins in the blood. And when we test the blood, if we detect 0 or 1 autoantibodies, the person has no diabetes. We don't see an increased risk. But when we get to stage 1, where there are 2 or more persistent autoantibodies to the insulin-producing cells in the pancreas, we know that this person over their lifetime will progress. People with 2 or more autoantibodies in stage 1 have normal blood sugars. Stage 2 is when we see 2 or more autoantibodies and high blood sugar, usually after meals. And then in stage 3, it's the classic diagnosis of type 1 diabetes. Usually there are symptoms, but not always. And then finally, established type 1 diabetes, where we see no remaining beta cell mass. So stage 1 is very important. We know from longstanding studies that the risk of progression at the 5-year mark, 44% of people will be diagnosed in stage 3, and at the 10-year mark, 70% will be diagnosed with type 1 diabetes stage 3 and require insulin. And again, the lifetime risk approaches 100%. I want to just say a little bit about stage 2, because the risk, once we see dysglycemia or hyperglycemia, again, usually following meals, checking a fasting glucose isn't going to get you there. The risk of a type 1 diabetes diagnosis accelerates. We see the time compressed to 60% of people will be diagnosed in 2 years and 70% in 5 years. And again, the lifetime risk approaches 100%. So once we see people in stage 1 or stage 2, this is our opportunity to intervene, but we can't know people have pre-symptomatic type 1 diabetes if we don't screen. And that's why screening is so important. And so what is T1 Detect? T1 Detect is quite simply an education and awareness program around type 1 diabetes risk screening and monitoring. And I just want to underline monitoring, because when we screen and we identify autoantibodies or those proteins in the blood that tell us that the insulin-producing cells are under attack, we need to do something following that. Because remember, the progression to stage 3 can take 2, 5, 10, sometimes 20 years. And so we want to monitor people so that we can prevent DKA at diagnosis, and so that we can engage people in research. Our screening strategy has 3 pillars. One is research, which you've heard about and we'll hear about again later this year. The other is health policy, which you're going to hear about in a moment. And in the middle sits T1 Detect, which is that outreach and education piece. Our goal overall is to build evidence for global universal screening or non-familial risk screening, and enhance our provision accuracy and really understand how often people should screen. We want to expand screening, our long-term goal, to all individuals, regardless of age, ethnicity, or their geography. And again, we mean global when we say it. And then again, emphasizing monitoring, because that's how we're going to continue to follow people and engage them in research, engage them in their own clinical care. And then finally, we want to really support, we're using all of this evidence to support evidence to marshal for policy change. So I'm going to talk just about T1 Detect. Our guiding principles: reducing the incidence of diabetic ketoacidosis at diagnosis. I'm going to say DKA moving forward. And then we want to identify individuals for prevention or disease modifying therapy research studies. And if we get an approved therapeutic, that would also be an opportunity. DKA rates are high at diagnosis in the United States. Prevention of DKA at diagnosis alone is sufficient to drive a program like T1 Detect. The rates in the United States are between 40 and 60% for children and adolescents. They are higher among racial and ethnic minorities. The rates in the United States are much higher than countries in Europe and Australia, and we have not moved the needle on this statistic. We don't have data on adults, that's why I'm not sharing it here, but I can tell you that in following children and adolescents who are diagnosed in DKA, they have a higher overall lifetime glucose levels. If you look at the bottom of your screen, you'll see that if a child or adolescent is diagnosed in mild or moderate DKA, their A1C over their lifetime is just under 1% higher on average. And if they're in severe DKA, meaning they have a very low pH at diagnosis, their A1C is significantly higher, 1.35% higher on average over their lifetime. We know that higher glucose levels are tied to complications over the long term. So this is a tremendous opportunity. We also know that DKA at diagnosis can affect cognitive or brain function and result in altered brain development. That's coming out of the DirectNet studies. So we really have a call to action on reducing DKA at diagnosis. We also believe that people need the information to make an informed decision about screening, and they need to understand the pathway. So a step-by-step roadmap is really critical. And on that roadmap, we want to start with why screening matters. Why should you get screened? What should be in your calculus when you make that decision for yourself or your child? And then we want people to identify the best pathway. So if you're eligible for research, that is likely the best pathway because you will get access to experts in the field. There is no cost involved. In fact, you may receive minor compensation to offset your time and travel. So we want people to identify the best pathway. If they're not eligible for research, there are other pathways available. And we worked really hard to get this information on our website at jdrf.org/T1 Detect. Oops, I'm going the wrong direction. Then we want people to get screened. And then we want them to review their results with their healthcare professional, whether it's an endocrinologist or a primary care provider. And the reason we have a little bridge on the map here is we have a lot of work to do in terms of making sure that when someone takes those results to a healthcare professional, particularly in primary care, that healthcare professional is armed with the knowledge to help guide the next steps in terms of monitoring. And I will say, as a past professor in nursing, I taught advanced pathophysiology at the graduate level. Pre-symptomatic staging of type 1 diabetes is not part of the curriculum. So we have some work here to do. If people are seen by nurse practitioners or PAs or primary care MDs or DOs, we really need to make sure they have the information to support their patients. We need an individualized monitoring plan. The plan for a 2-year-old who screens is going to be different from a 20-year-old and different from a 70-year-old. And then finally, we want ongoing evaluation and engagement so we can get people to clinical studies, or we can get people the education they need to prevent DKA at diagnosis. We've got 3 pillars. So I've pretty much covered this, so I'm going to keep it short here. But again, education and awareness for people in the type 1 diabetes community and for healthcare professionals. Screening, we want people to know about the research pathway. We want people to know that they can, if they're a healthcare professional, they can prescribe clinical labs to Quest or LabCorp or another resulting agency, or an at-home pathway. They can use the Enable Biosciences kit. And then finally, monitoring support. What to do after you screen. Peer support, we believe that's something JDRF can provide, because there's a lot of people in our organization who have walked this road and can provide meaningful peer support. And then finally, monitoring advice, and really looking at monitoring guidelines. And again, the goal here to improve outcomes and accelerate disease-modifying therapies. Oops. I want to stop here just for a moment, because it's important to note that there was a big change to the standards of medical care in diabetes from the American Diabetes Association in 2021-2022. And prior to this publication, screening was only recommended in the research setting. In 2021-22, remember these are living guidelines, the screening recommendation was actually expanded to first-degree relatives of individuals with type 1 diabetes, and that's new. And And frankly, there's not a lot of screening happening in the clinical space. But we see this as a key opportunity at JDRF. So our long-term goal hasn't changed. And when T1 Detect first launched, you might have heard, get screened now. And certainly that's still a call to action. We want to get to global universal screening. But in this fiscal year, between now and next June, what we're looking at is a more intense focus on that recommendation in the clinical guidelines, the familial screening, and specifically first-degree relatives. If we estimate from the T1D index that there are about 1.4 million Americans living with type 1 diabetes, we know from data provided by the NIH that about 250,000 have been screened in the research setting. This leaves, I think, at a low estimate, about 5 million first-degree relatives in the United States who have not been screened. This is the lowest hanging fruit, and we all need to get behind and get lined up, hold hands, and move forward and get this done. Because as you know, first-degree relatives have a 15 times higher risk for a diagnosis of type 1 diabetes. So what are we doing in fiscal year 2023 over the next several months? I feel we're already in November. Well, we want to educate healthcare professionals, as I mentioned. The next piece, and I'm going to go over these in a little bit more detail. The next piece is we want to educate JDRF staff, volunteers like all of you, and the type 1 diabetes community more broadly. We see you as our best advocates to talk about screening and its importance. We want to expand some work we've been doing in clinical pilots to diverse populations, and I'll say a little bit more about that in a moment. We want to enhance the information we have online, that we have in print, so that people can easily understand why they should get screened, how to do it, and what the next steps are. And then we're working with partners with key opinion leaders, academics, and other organizations to get consensus monitoring guidelines, which at this time don't exist. So we have guidelines around screening, but not around what to do afterwards. And we need to sort of close that gap. So let's talk a little bit about healthcare professional education. We embarked on this at the beginning of the fiscal year in the middle of your screen there with some nurse practitioners at a national symposium, and almost none were familiar with pre-symptomatic type 1 diabetes as we suspected. But what was a little surprising, the same was true at ADCES among diabetes educators. And so we've identified some conferences for this fiscal year: ATTD, which will take place in Berlin, the Pediatric Endocrine Nursing Society, and the American Diabetes Association in June. And we will be having symposia at these conferences, and we'll be directing the dialogue to the attendees at those events. We're also working on strategic partnerships. So we had a blog with ADCES, our diabetes care and education specialist partners. And surprisingly, this blog was shared over 45 times and had significant interaction online. This isn't the type of thing you think is going to be big on LinkedIn, but it was. So we know there's a hunger for this information among healthcare professionals. And we will be exploring something called Tweetorials, which is a 0.25 CME. So for those of you who are healthcare professionals, this is something new, but we want to meet people where they live. And if we need to educate on Twitter, we're going to give it a try. I just want to draw your attention to our upcoming symposium at ATTD. We've got some extraordinary key opinion leaders lined up: Michael Haller from the University of Florida, Chantal Matthew, who is the incoming in leadership at EASD, and then Kimber Simmons, who is at the Barbara Davis Center, has been doing some excellent work around providing monitoring support. So stay tuned for that and for a follow-up tutorial. What about staff, volunteers, constituents, and just the community writ large? The community of people affected by type 1 diabetes. Well, internally, we've been doing some lunch and learn events. We will be doing those quarterly. We want to make sure that every person at JDRF is up to speed on what's going on in global universal screening. We held a virtual Type 1 Nation Summit in October, earlier this month, that was well attended and had some great questions from the group. And we will, in calendar year 23, have an educational track at the in-person Type 1 Nation events, at 10 of these events around the country where we'll be talking about screening. And we actually do this in an interactive way. It's not quite a game show, but there's some Q&A to sort of understand the things people know well and the things people need more information about. And we give away some prizes. So if you're going to be at a local event, please attend. And we're actually looking for some RIVs to take on these presentations in the future, and we can talk about that on the call. And finally, we'll be expanding our presence at Friends for Life. I just want to show you some polling results from our online virtual summit on October 6th to show you where some of the learning needs are in the type 1 diabetes community. These are folks who attended this event on a Tuesday night. I think it was a Tuesday. It might have been a Wednesday, but on a Tuesday or Wednesday night, they are interested in screening. We had just about 130 people. And you can see when I mentioned earlier that the risk for type 1 diabetes for family members is up to 15 times higher. Only a small minority of attendees got that right. There's also a lot of confusion around the staging of type 1 diabetes. And again, a full 15% here said, I have no idea how many stages there are. And many said one stage. So I think we have some work to do just to make sure people understand staging and understand the importance of screening. Moving on to some pilots, and I'm going to spend a little bit of extra time here, but in fiscal year 22, we activated 2 pilot sites, and they are on your screen to your right. The first is a large university affiliated hospital at Rutgers University. So Aaron Kowalski's alma mater in Newark, New Jersey. And the children and families in this clinic speak a number of languages, including English, but also Spanish and Portuguese and Creole and Urdu. There's actually no TrialNet site in the state of New Jersey. I wasn't aware of that before taking this position, but and I should have known that because I worked on TrialNet. But at any rate, this was a real opportunity to bring screening to families who might not have been invited in the past and make sure that we were partnering with the clinic. This is clinic run, but making sure that the clinic was providing, again, the why of screening, the how of screening, and then the follow-up monitoring. What's happened so far in this clinic, which approaches 100% racial and ethnic minorities, is we have screened the clinic has screened nearly 150 individuals. They are providing patient-facing materials in English and Spanish to make sure that the information is more accessible. They have hired a bilingual patient navigator that is helping families not only with screening, but other aspects of diabetes care, because in this setting, it's a sole practitioner pediatric endocrinologist. This setting does not have the luxury of having diabetes educators and psychologists and child life. This doctor is functioning as a sole practitioner. And so we're hoping not only can we educate about screening, but also provide additional support. At the other end of the spectrum, we have the Adams County Health Clinic, which is in a small town called Council, Idaho. And there are only about 900 people in this town. It's a rural federally qualified health center. We're also subsidizing the test kits so that screening can take place here. Again, a group of people who might not be invited to screening. And we're helping this clinic build internal and external capacity for screening and follow-up monitoring. And they're actually partnering with an organization called Ask the Experts, the Barbara Davis Center, to provide remote follow-up monitoring, because this is a nurse-led clinic and they felt they needed that additional support to do follow-up monitoring. We've identified additional sites for fiscal year 23. We will be activating them. We actually are in the process of doing that this week. We're trying to explore staffing models. What works to support families in making these decisions, and what works in the clinical setting? Because remember, the guidelines recommend screening in the clinical setting, but it's not really happening yet. So how do we create evidence to do that and then partner with investigators in academia and in the clinical care setting to make this happen? And we're also testing out those patient-facing materials to make sure that they make sense to people. Something I learned in clinic a long time ago is often what I say is not what people hear. And we want to make sure that the clinics have materials that make sense to people who are reviewing them. And finally, we need to enhance what we've got online, improve our digital communication, starting with our website. So we had one version of the website. We're now at version 2.0. We actually have what I think is called a wireframe, and we're working on version 3.0. We want to get more of this in video, and during National Diabetes Awareness Month, you will see a story of the Hulsinger twins here to your left, one diagnosed with type 1 diabetes at 2, the other who screened positive for autoantibodies and wasn't diagnosed until 6 years later, but with a very low A1C and with very little hyperglycemia. And their mom also has positive autoantibodies, and they'll be talking about that experience in the TrialNet study. We want to work on our print resources. And again, getting those materials in both English and Spanish, and someday when we have the capacity, other languages. I just want to show here that we can drive people to the website. We did some paid advertising back in April and then again in September, and the jdrf.org/T1Detect became the #1 visited site on jdrf.org, period. So we know we can get people to the site, but what do they do when they get there? That's what we're working on next, and we want to make sure that they have the material they need to make, again, an informed decision about screening and their healthcare. I'm going to switch gears and turn to clinical trial education. So this is a program that a lot of people are involved in. So Brian Herrick is on this call. He's involved. Rachel Webb, Alex Mulvey, Janie Boodle. There's a whole bunch of people, and so too for T1Detect. And I should call out for that program Erin Turner Pfeiffer and Campbell Hutton and Katie Doyle, Janie Boodle, and a whole bunch of people in research. But this program, clinical trial education, our goal here is to create a culture of research participation in the type 1 diabetes community. And I purposefully said type 1 diabetes community because it's not just at JDRF. This is across type 1 diabetes. If we engage more people in research, we move science forward at a quicker pace. We rule things in and rule things out. And ultimately, we get to cures and better treatments faster. So this program has 5 components. The first is a program called the Clinical Trial Education Volunteers. The second is the Clinical Trial Connection Tool. The next is education and outreach, and most of that is kind of online. We're working on improving the evidence base and putting some evidence behind best practices. And finally, something new is a participant advisory council. So let me go through each of these briefly. The first is the Clinical Trial Education Volunteers. This is up to now 24 local volunteers, and we are growing at a reasonable pace because we want to make sure that we do it well. And these local volunteers work in partnership to educate their local community about the importance of clinical trials, what they are, how to enroll, what to expect when you get there. They want to inspire people to learn more about research participation. Only a minority of people participate in research. We need that number to increase. And we also need people from all walks of life, a diverse group of participants, because that's not what we see typically in type 1 diabetes research at this time. And finally, we want to connect individuals and families to local study investigators and let them talk about inclusion criteria, et cetera. So what are these volunteers doing? Well, they've got banners, and they've got table coverings, and they've got QR codes, and what are they doing with them? They are hosting tables at Type 1 Nation events, at walks, and at galas to educate our community. They're attending pop-up study updates, and these are, we keep them fairly small so that there can be a lot of interaction between the volunteers, staff, and the principal investigators. They have access to a clinical trial dashboard, and they can download spreadsheets from that dashboard to share those local studies that are enrolling locally with people in their community. They represent JDRF on a number of panels, and sorry, this is not a complete sentence, but for example, one of our volunteers went to Bethesda and represented people living with type 1 diabetes at a beta cell therapy symposium that was promoted by JDRF and the NIDDK. They connect individuals and families, again, to local clinical trial coordinators. And then we have an online hub for them, and I'll let you read through that. But the hub basically hosts a lot of resources that they can use. They can print things to have at their tables. IRB-approved study flyers are there, and they can also pull down videos or text that they can share on their social media or via a chapter newsletter. And in fiscal year 23, we're asking these volunteers to get outside of these typical JDRF events and reach an underrepresented population in their market or in their chapter. We have been working with Ashley Butler at the University of Alabama at Birmingham, who is a psychologist, but really works on diversity in clinical trial participation, because we wanted to bring some expertise to these events to make sure that we were doing them in an authentic and in a very purposeful way. So more on that probably next year. I just want to share with you the clinical trial dashboard, and there's a link below that you can click on this interactive dashboard. And again, you can find the recruiting clinical trials by chapter. This is really important because you can see what's recruiting nearby, and then these volunteers can become familiar with these trials and share information about them. all the way on the right, you can't see it in this bar graph, but all the way on the right, there's a section for virtual studies. And more, we're seeing virtual studies that recruit all over the country. And this means that you don't have to live in a specific geography to participate and to contribute to research and to contribute to science. And we want to make sure people know that's an option as well. So get online and check this out. And again, a shout out to the team for making this possible and adding to that another name, Matt Whipple in research. And then I just wanted to show you here where the clinical trial volunteers are up and down the coast, but we will be adding in the southern states. Again, we want to pick up University of Alabama at Birmingham. We want to pick up North Texas and Oklahoma, and we'll be picking up somebody in the Desert West, because one additional point is clinical trials, including most of the prevention studies, have travel funding. So when I worked in research at the University of Florida, we flew people down to Florida from New York to fill our study. And so you don't necessarily have to live nearby to participate. And usually those costs are covered. So we will be adding participants here because we don't want to leave people out. We also want to build the evidence base. JDRF a couple of years ago funded a study to understand the barriers and facilitators to clinical trial participation in pediatric type 1 diabetes. Sarah Weston is a psychologist. She is writing up that manuscript, and we hope to have it submitted this year. We also want to work on surveying the scientific literature to describe already known barriers and facilitators to participation in type 1 diabetes research. And then we also need to focus on diversity, because we know that people who identify as with a racial or ethnic minority group often are left out of research. And if we don't include everyone in research, we will not have cures for everyone when we get the results from studies. And so we need to make sure that we are identifying unique barriers and making sure that participation and access is open to everyone. And around this role, we're looking at what's the principal investigator's role in diversity, inclusion, equity, and belonging. And then are there practices that are already taking place that support diversity and inclusion? And in part, this will be informed by what a lot of clinical trial coordinators are already doing, but we want to get this down on paper. So we will be working, again, kind of in the background on getting some evidence so it will drive our activities. Finally, I mentioned sort of education. So we're producing some educational videos to do several things. First, we want to make sure people know what a clinical trial is or a clinical study. And we want people to know that they should participate at a level that makes them feel comfortable. So if they feel comfortable answering a 2-question survey in clinic to contribute to a better process for type 1 diabetes care, that's wonderful. If they want to participate in a 14-day infusion of a therapeutic, that's also wonderful, but they need to make a choice based on their personal needs and any concerns they might have. So we want people to know what clinical trials are. We want them to know why it's so important that they participate. And that's because clinical trials are often delayed or aren't even completed because we don't have enough participants. Again, underlining the importance of diversity in clinical trials. We want to talk about prevention and screening because without prevention, we don't have a cure, and we want to do things in Spanish language. We are working this year to place these in clinic. We want people to advocate for themselves to participate in research, and sometimes in a busy clinic, research doesn't always get mentioned by the healthcare professionals. We want to cue people to ask. And then finally, we're having, actually now it's looking like twice a month webinars. So semi-monthly, where we have our clinical trial education volunteers and staff, and they're learning about studies that are having challenges recruiting. And these are JDRF and non-JDRF funded studies. We most recently heard from Carla Greenbaum at TrialNet on the TOPL T1D study, and that has an end date on recruitment in early December. So please have a look at that. I'm just putting in a small commercial so we can move that forward. But again, we want to make sure people know how to participate, know why they should participate, and know how to make that connection. I'm almost done here. So we want to bring more people in to learn about clinical trials as well. And so there's a couple ways that people can do that. The first is, I think all of you are familiar, and this is something that I want to give a shout out to Brian for, is the clinical trial connection tool on the jdrf.org/clinical trials website. In 60 seconds, you can match to a clinical trial, and this this software goes out and pulls trials off of clinicaltrials.gov, and it tells you trials that are within 100 or 50 miles of you. So it's very helpful. When people use that tool, they can opt in to give us their email. So that's this box on your bottom left. And when we get their email, that's the only thing we get about them. So we actually now send them 2 emails saying, you know, we know you're interested in research. We certainly would love to tell you more about research, particularly research that's happening where you live. Can you give us a little more information? Over 10,000 people have given us their email. I think just over 2,000 have given us more information. And right now we're building a process for clinical trial education volunteers to easily communicate with these constituents and really keeping this focused on clinical trial content and not a lot of other JDRF content at this time. People can also opt in by just filling out a form on the JDRF website. And that's really helpful because if they don't want to do the Clinical Trial Connect tool, they can simply give us their email online. Wrapping up here, our last point is the Participant Advisory Council. This is new to JDRF. We get a lot of requests from study investigators, from startup companies in the type 1 diabetes therapeutic space who say, we're designing a study. We'd love to talk to someone with type 1 diabetes or someone with pre-symptomatic stage 1 or stage 2 type 1 diabetes, or a parent of a very young child with type 1 diabetes to understand what study design would be acceptable and would make sense for that individual or that parent. So we are building what's called the Participant Advisory Council. This is a group of volunteers to inform study design. This will be parents of children with type 1 diabetes and who have children at risk, so who are autoantibody positive. It will be adults living with type 1 diabetes who were diagnosed as children or adults, and individuals at risk for type 1 diabetes who are in stage 1 or stage 2. We want to represent everyone in this council. So people from diverse racial and ethnic groups, genders, rural and urban settings, and different insurance status, public, private, and uninsured. And you'll be hearing more about this group. We hope to launch at the end of November. And again, we'll be happily take questions when we're on the call. I'm not going to linger here, but what I've emphasized in this talk are our 2023 milestones that we are attempting to achieve. We did pretty well in 2022. And again, this is our trajectory over the next 5 years. And I'm happy you can pause your screen and look at these, and I'm happy to take questions when we meet in person. And now I'm going to hand it over to my colleague, Erin Turner Pfeiffer, to talk about health policy.
Thank you, Anastasia. And we are going to shift gears a little bit from the research and screening side. We'll talk a little bit about screening later. There's a little bit of a tease, but we're going to talk here about health policy and the role that the health policy team and the health policy issues are playing in advancing JDRF's mission. For folks joining late that might have skipped ahead, Erin Turner Pfeiffer, Director of Health Policy here at JDRF. And many of you are likely familiar with the pipeline, or hopefully you're familiar with the pipeline. On the left here, you can see of your screen, JDRF's efforts around research, conveniently and appropriately placed right in the middle of the pipeline here is our efforts around regulatory policy and regulatory approval. Moving over to the right side, healthcare coverage and clinical adoption. And surprise here that the big red circle highlights where most of our health policy work is focused. We do work and support the community engagement team on many things around clinical adoption, but the meat and potatoes of the work that the policy team is doing is really here focused on healthcare coverage. And so we'll get into some details around what that looks like. And so health policy at JDRF and health policy team is focused on ensuring that folks have access to the innovative therapies that JDRF is funding from a research side and working through and moving through the pipeline. We want to make sure that folks have access and affordable access to those therapies. We also want to ensure that folks are getting access to standard of care and are having better outcomes via insurance design, employer benefit design, and then clinical care and clinical coverage. And so what that looks like in practice is a number of different things. In some efforts, in some ways, the health policy team is leading those efforts, and in some ways, we are supporting our colleagues on the advocacy team in different ways and different roles. And so health policy issues writ large, we approach through a couple of different strategies and tactics. One, we are a resource for the community. Two, we directly engage decision makers. These are either folks in government at the White House and Congress, at the Department of Health and Human Services, Medicare and Medicaid regulators, but also directly with employers and health plans, other stakeholders, depending on the issue, could include manufacturers of devices and drugs. We really do make an effort to directly engage decision makers and not just provide resources, but we want to make sure that folks are aware of the issues that are happening in the type 1 community, as well as the impact that those decisions are having. As you all are aware, we have a vast and great grassroots network, and the health policy team provides support for folks as they're directly engaged in Congress and their health plans and employers. All these things are interconnected, right? And so the resources that we provide to the community also are a great tool and resource for the grassroots team. And then we also partner with allies, so other advocacy organizations, and where appropriate and where possible, stakeholders in the industry to advance JDRF's goals and mission. So I just wanted to highlight one of the great resources that we have that's provided to the community and maintained and supported by Jackie LeGrand on the health policy team is our T1D health insurance guide. Every year it feels like we add a new term to health insurance that makes it more complicated, or a new wrinkle that complicates things further. And we try and do a good job of ensuring that the insurance guide is a good resource to help folks navigate both open enrollment, but also plan and get through some of the barriers that are going to come up in a plan year. This is available as a resource on the JDRF website. I'm really encourage folks to utilize this. It does do a great job of walking folks through some of the common terminology that is often just a barrier to understand kind of some of the dynamics that are at play within your health insurance. And it covers both commercial insurance, Medicare, and we do have some resources on there highlighting different elements of Medicaid plans as well. So I wanted to highlight that for folks, and then talk a little bit about our direct engagement efforts. And we use this umbrella campaign, Coverage to Control. Hopefully some of you all have seen it online and have participated in this, but we use this as our umbrella to engage on a number of different issues, but there are three key elements or three key issues over the last couple of years that we've engaged on. Under the affordability bucket, we focused around insulin affordability. Choice is to give folks choice to utilize the insulin pump that works best for them. And then coverage, we want to make sure that all life-saving technology, including the artificial pancreas system, is covered by insurers. And so on the policy side, we're always looking for improved access, and we really kind of organize these around affordability, choice, and coverage with some key areas to address that we think employers in particular and their benefit plans, but as well as employers and others may not be providing the best coverage and decisions in their benefit design. So we'll talk about these three topics in a bit more detail here. But first, I want to highlight the new area and build off a little bit of what Anastasia was highlighting. And Cures Access is what you saw was not covered and directly in Coverage to Control. But Cures Access is one of the emerging areas that we're spending a lot of time on the policy side. You can imagine moving through, and as we have therapies moving through the pipeline now that have gone from research or pending regulatory approval, we're looking at what access looks like to these therapies and what coverage looks like for these therapies. And it's an exciting time on the policy side to try and build out an infrastructure that ensures there's affordable access to these therapies that are coming. So I just want to spend a little bit of time here talking about what that looks like and the health policy team's role in advancing access to these cures therapies. In the left here of your screen, you can see the current state. And so when we talk cures access, we're talking screening, monitoring, as well as access to the therapies themselves. And in some cases, monitoring is the most appropriate path forward for care. And so we think of these kind of three elements together as we're talking about cures access. And right now, the landscape is at best uninformed and unformed and unstructured in terms of coverage. And so screening and monitoring is not part of routine preventative services. It's there's no clear methodology around how payers are paying for screening and monitoring. And there's some emerging dynamics that are starting to reveal themselves as we get closer to having the first disease-modifying therapy for type 1 diabetes hit the market. But again, no clear pattern of how these things are being covered. And there's, in our experience engaging with payers, the broader provider community, there's limited awareness around screening, monitoring, disease-modifying therapies and cell-based therapies in type 1. And so we've got a lot of work to do to get where we want to go, the future state, which is broad, elevated knowledge amongst all the stakeholders. Screening for type 1 diabetes is routine for everyone. So general population screening that Anastasia was talking about. And there's broad coverage, both by commercial payer programs as well as government programs, Medicaid and Medicare. And so we have a lot to do to get there, to build an infrastructure, not just the infrastructure around research, and there's the infrastructure working with the regulatory folks on the FDA side to move these things along. And we've done a tremendous job of building that infrastructure out to get us where we are today. And so the health policy team really picks up the baton to help build out both the insurance structure and coverage that's required, as well as work with Anastasia and the community engagement team to make sure there's a clinical infrastructure to support screening, monitoring, cures, therapy access. So we think about this in a couple of different ways. Underpinning access to curative therapies, disease-modifying therapies, and cell-based therapies is broad access to screening and monitoring. We think of these things as foundational elements to ensure that there's access to the therapies themselves one day when they do come online. And so there are two buckets here. They're mutually supportive, moving at the same time, but potentially under different time horizons. So what we call the public policy campaign, this is clinical adoption, ensuring there's reimbursement and insurance coverage for screening and monitoring. This is happening now, and there's data that JDR has been supportive of generating, and others in the community that provide both a clinical foundation. There's clinical guidelines being updated that highlight the importance of screening and monitoring. So we are doing our best to advocate and inform the environment so there's coverage of these services now. And a much broader efforts we call public health campaign is changing over the long term, the ADA guidelines, including that there are screening and monitoring requirements and pediatric guidelines. And then ultimately, the Preventative Services Task Force it will recommend screening, type 1 screening and monitoring. And if you, on the public health campaign here, if you check all these boxes, so if you can generate enough clinical data that demonstrates the value and importance of screening, both ADA guidelines updated, the Association of Pediatricians, Bright Futures, and then the U.S. Preventative Services Task Force recommendation. These elements, both either by law or by custom and practice, often trigger automatic coverage and reimbursement through the insurance system. So each step here on the public health campaign have different requirements, different data expectations, and they just require a bit more time to prepare and present materials. And so the time horizon here on the public health side is much longer. That doesn't mean that we won't get there, and that doesn't mean that there's not going to be coverage happening via the existing insurance system and via different pathways in which health plans and government programs will cover different services that have yet to be endorsed by the Preventative Services Task Force, as an example. And so those are things that we are building now. It's very exciting. We are at the start of what will likely be a long journey, but it is already bearing fruit, and we're very excited to continue on in these efforts and really for the first time build out and support the building of coverage for type 1 diabetes screening, monitoring, and access to curative therapies. So that is very exciting, some of the new work that we are engaged on. I want to talk about some of the work that you have probably come across that we are working on. There's not, as I say, there's not a day that goes by that we aren't working on the issue of insulin affordability, given its importance to our community. And so just a couple of things here I want to highlight in terms of our advocacy. This is not just the health policy team, but our advocacy team writ large is working on both on government policymakers, but also working directly with other stakeholders outside of government to make sure we're lowering the cost of insulin. So no one should go without insulin because of cost. All of our policy efforts are focused on that. And a couple of the areas where we've really driven and tried to educate decision makers is around the impact of the rebate system. Designing your benefit plan has a huge impact on someone with diabetes, and the level of education and knowledge, especially amongst employers and HR professionals who are making these decisions on behalf of people they employ with diabetes. We've been focused on the last couple of years. We're starting to see a lot of fruit from those efforts come to bear over the last couple of years. And so there have been good strides in progress around improving benefit design that we're happy with. We have a long way to go, but certainly happy with the progress we've made. And we try and where we can provide resources. There are a number of affordability programs that are being offered either by other not-for-profits or by the insulin manufacturers themselves. And so we're always a resource for folks who are in need. And this last point here I want to highlight, we're constantly working all the stakeholders in the drug supply chain to do their part to lower insulin costs. So we're not just focused on federal legislation and federal policy changes. We're also directly engaging insulin manufacturers, health plans, and employers to do their part to make these changes as well. So I just want to, I touched on this a bit. Just want to highlight here some of the progress. The Inflation Reduction Act, took an important step, certainly didn't go far enough. We're continuing to work for legislation that will provide relief for top-line insulin prices as well as cost protections for the commercial population, but the Inflation Reduction Act did cap insulin costs out of pocket at $35 a month for folks enrolled in Medicare. We've seen over the last year more studies, more data points coming out showing it actually makes 0 cents to charge someone out-of-pocket cost for life-saving medication. Often insulin is the example used in these data points. And so we've seen more insurers and more PBMs moving in the direction of capping out-of-pocket costs for insulin, including United Healthcare a few months ago making that announcement. And so we're again, baby steps, but trends are moving in the right direction for those populations. We've seen manufacturers enhance their assistance programs. Certainly don't want to be in a situation where we have to ask or expect manufacturers to provide assistance because their insulin is so high priced, but it is certainly a lifeline for many, and it's an important element that continues to be offered. We've seen some manufacturers offering both a high price branded product and a lower price unbranded product. Again, not ideal, but access to a lower price insulin again, is a lifeline for many. And so that's an important element that continues to be offered and an important development in terms of manufacturers' business strategies. And the last point here, I'll touch on the next slide, the Civica partnership, I think is indicative of JDRF's efforts around insulin affordability. And as I've said, we have a long way to go, but we have made progress in a number of ways. And I think one of the things that highlights the work that the community has done writ large in raising this issue is there was a time when folks, especially in government, weren't paying attention and weren't talking about the impact of high insulin prices on people with diabetes. And now it is the number one example of the broken system and the impact of a distorted system that rewards higher list prices and the impact that has on the people who take those drugs. And insulin is the number one example. JDRF has been at a couple of events over the last couple of months at the White House where insulin and type 1 diabetes has been a focus mentioned by the president. And this is bipartisan. We have received support for lower insulin prices from the previous administration as well. And so I think that's a testament to JDRF's work and the work of the larger type 1 community that we're at a point now where we are getting awareness and attention on this issue and are seeing small but steady improvements in the availability of low-cost insulin. And so I want to wrap here on the talking about insulin around, this wasn't just the health policy team. This was really an organizational effort and an advocacy team effort to try and do something different, right? And so many of you have seen JDRF's announcement of supporting and partnering with Civica and other leading healthcare stakeholders to try and disrupt the insulin market. We know that we have seen steady progress, but not enough is being done to truly lower the list price. And this is an issue that needs attention now. And so in that vein, JDRF is partnering with Civica to offer the lowest priced insulin available in the market at $30 per vial, $55 for a box of pens, and really cut out and get around the distorted effort that rebates are having. And so not only will this provide a low-cost insulin for millions who need a low-cost insulin, it will provide some peace of mind. So if you're getting mail-order insulin, it doesn't make it in time, you don't have to fear having to go and pay out of pocket at a cash price of $400 for a vial of insulin to bridge to get you through until your next shipment arrives. You're going to have a low-cost insulin from Civica available at $30 a vial. The other piece of this that's just as important is to disrupt a distorted market and demonstrate the value of having low-cost insulin available. And so we're very excited by this opportunity. The Civica team is making good progress and good strides and making sure the first insulin is available as early as 2024. So our marketing communications team does a great job of working with the Civica team to keep folks updated. Again, look for press releases and social media updates as we get closer to 2024 for this, but want to highlight that this is an area where we're not just waiting for government action or health plan action to lower insulin prices. We're also doing what we can to provide relief as quickly as possible. So I want to wrap here by talking about devices. And one of the great things that I've been in this role at JDRF now for about 2 years. And one of the great things around working on the device issue is being able to come in at the end and forgive the sports metaphor, but spike the football here, building off all the great work that's already been done by so many. Just as a reminder, on our coverage to control campaign, we focused on devices around choice and coverage. And what's great is we've gotten to the point now where we've in large part achieved what we set out to achieve when we launched the coverage to control campaign as it related to devices a couple of years ago. And so commercial insurers by and large now cover CGMs, and they cover artificial pancreas systems. They by and large now cover all the approved insulin pumps. Recent changes. Medicare has caught up to the commercial side, and they're covering insulin pumps. They're covering CGMs that are available in the market. And so we've made tremendous strides, and JDRF really has been the driving force behind this for the last decade of getting CGM accepted and ubiquitous coverage on the commercial side, the driving force getting Medicare to catch up to standards of care and cover CGMs and artificial pancreas systems for those who are enrolled in Medicare. And so there's been tremendous strides made there. And as is often the case, unfortunately, Medicaid is still lagging both the commercial and Medicare side, but there are leading states that are now covering CGMs and artificial pancreas systems for kids. And so, progress there as well. Some emerging issues. And so one of the things that I try and highlight for folks is we've reached a phase now with insurance policy, both on the government side and on the commercial side, where they're no longer questioning the value of CGMs and insulin pumps. And we've gotten to the point now where this is just the American insurance system where they're starting to pick their favorite devices, which is creating issues of choice for folks. And unnecessarily forcing folks to change devices that otherwise were working for them. But that is the issue we wanted to have, right? So when we started this effort, JDRF started this effort a decade ago, it was hard to get coverage, and now everyone's covering it, and we're working through the unique machinations of the American system. There are some questions around the next generation of devices. And so how is coverage interacting or impacting devices where there's now an interaction with a cell phone and an algorithm? And so those are unique challenges that are starting to present themselves. And we know on the commercial side, as devices are moving from a durable medical equipment benefit to a drug formulary, there might be some challenges associated with that. So we're paying close attention there. Medicare is unique in that it is, once you've got something covered, you can kind of put that issue to rest because they rarely go back and change something. But they're often, as we've experienced, slow to adapt to innovation. And so we know that the device space is rapidly innovating, as I mentioned, with interactions with cell phones and algorithms. So that's going to be a tweak of how Medicare covers that. And we're still looking for Medicaid, the Medicaid states to catch up to where commercial insurers have been, where Medicare is today. The Medicaid space is still lagging. And so we're working with our allied partners to see what we can do to speed Medicaid coverage up. But a great time to actually be looking at device access. We've come a long way. And so we should be just tremendously proud of our role in this and the impact we've had. So in conclusion, if you skip to the end, I get it. I could talk about insurance in my sleep, but if you skip to the end, just a couple of key things to take away. The health policy team is an integral role in accelerating affordable access to innovative and life-improving therapies. We do that through direct engagement with stakeholders and policymakers, but also supporting other elements of the advocacy team that are doing the same. We are focused in a few key areas that we're driving solutions on, both on insulin affordability, device access, and cures therapy, which is kind of the new thing that we're excited about and really eager to be working on. And this last piece here is just a note, we really are a resource. We have the insurance guide, encourage folks to use that and share that. But we really are a resource for staff, volunteers in the community. Feel free to reach out to me directly if you ever have a question about anything that JDRF's doing, if you have a question about something that's happening on the insurance side. But also, shameless plug here, it's one of the ways that we stay informed is, just folks sharing intel that they're aware of that's happening out there, sharing that directly with us. It helps us keep a good finger on the pulse of what's happening in terms of insurance changes that are impacting the type 1 community. So with that, thank you. It has been a pleasure to talk about health policy with you all, and hope to connect with you soon.